Hi, this is Dr. Perry Carpenter. I'd like to thank you for joining me on today's program. Today's program is from the Special Population Series, and today's program is entitled Exercise Prescriptions for Orthopedic Injury and Rehabilitation Clients, or in our case, we could refer to those as chiropractic patients. I have a fascinating program for you today, and it's a program that I'm sure will provide invaluable information for you as you handle your chiropractic patients that have specific conditions that require your help in the rehabilitation of those conditions. And let me just take a moment to introduce myself to you. This is Dr. Perry Carpenter. I'm a chiropractor. Been a chiropractor for approximately 28 years now. I graduated from Palmer West College of Chiropractic. And throughout the years, I've taken many different types of continuing education courses. And I list for you here some of the courses that I've completed that qualify me to speak on today's topic. And specifically, I'm going to be making extra reference today to materials derived from the National Strength and Conditioning Association, of which I'm a member. I hold two credentials with the NSCA. I hold the Certified Strength and Conditioning Specialist credential and also the Certified Special Population Specialist credential. And today's material is largely based on ideas, references, and concepts about rehabilitating and treating persons who qualify as special populations. And today we're talking about that group of special populations that we find in the chiropractic practice, and that is people who have healthcare issues. Specifically, today we're talking about injuries and issues with the musculoskeletal condition. So today's program is about injury, orthopedic, and rehabilitation patients. And those certainly qualify as special populations. And those are certainly people that have special and unique needs perfectly suited to the work that we do as chiropractors. So I'm going to be supplementing chiropractic material today with additional material derived from the exercise sciences. And I will be quoting some references from the National Strength and Conditioning Association. References for today's program are many, and draw your attention to a couple of textbooks from the National Strength and Conditioning Association. I'll be presenting information from the Essentials of Personal Training and also the Essentials of Strength Training and Conditioning. I'll also draw upon material out of Lippincot's Primary Care Orthopedics 2nd edition. I'll refer to Yoakum and Rowe Essentials of Skeletal Radiology, specifically when we get into a discussion later on the rehabilitation of spondylolisthesis and spondylolysis. I'll be drawing on some physical examination procedures from the Fundamentals of Musculoskeletal Assessment Techniques. That's a fabulous textbook by Palmer and Epler, a couple of physical therapists. I'll make also a brief reference to the AMA Guide's 5th edition, and those of you that are qualified medical evaluators, you'll recognize those references. And then I have a couple of specific references for you relating to the shoulder and the lumbar spine. And I chose and selected these references for a couple of different reasons. Number one is they relate exactly to topics that we're going to be discussing, specifically related to the lumbar spine and specifically related to the shoulder. And also because each of these articles illustrates some general principles that are extremely important principles that we understand regarding injuries and rehabilitation in general. And I'm going to make early references to each of these principles early in the program. And then when it comes time, when we get to the lumbar spine section and when we get to the shoulder section, I will reiterate these principles by drawing upon these references, specifically as relates to the region that we're considering, whether it be the shoulder or the lumbar spine. And I know you're going to find these references to be fascinating, and these are some principles that are illustrated in these references that you can rely on and that you will rely on in your practice from now to forever. Okay, so osteoarthritis, and this is a definition that comes out of Yoakum and Rose, the Essentials of Skeletal Radiology. They define osteoarthritis as a progressive, non-inflammatory disease, and let's just stop right there. There are many scholars and researchers who believe that the term osteoarthritis is an outdated and misnomerous term because the suffix itis suggests inflammation, correct? So you're familiar with bursitis and tendonitis and itis simply referring to the presence of inflammation. Well, osteoarthritis itself, by definition, is non-inflammatory. It's progressive, but it's non-inflammatory. So for that reason, many scholars are discarding the term osteoarthritis and replacing that with the more descriptive term degenerative joint disease, or DJD. So DJD is characterized by degenerative pathologic changes in the articular cartilage and its related components. We'll talk about the articular cartilage and the related components here in just a couple moments. Now, degenerative joint disease typically involves the small joints of the hands, and then of course involves the larger weight-bearing joints. And it's the larger weight-bearing joints that's going to be responsible for bringing the patients into our office with complaints of pain. Typically, we're going to see osteoarthritis or degenerative joint disease in the spine, in the hips, in the knees, and then to a lesser extent in the ankles, and then to a much lesser extent in the upper extremity articulations that are subject to a lifetime of repetitive motions, such as the shoulder joint and the hands, the glenohumeral joint, and then the small joints of the hand and fingers. Okay. So with osteoarthritis, there's a progressive deterioration process that ultimately results in the characteristic findings that we associate with degenerative joint disease. And it's associated with the appearance of degenerative joint disease that we typically see on an X-ray film. So the first stage is a lifetime of repetitive physical and or chemical forces. The constant downward pressure, particularly on the weight-bearing joints, causes an altered chondrocyte function. Now remember that the chondrocytes is the name that we give to the cells that are responsible for making the joint cartilage, the articular cartilage. Now, articular cartilage is largely hyaline cartilage. There's many different types of cartilage. We have fibrocartilage, we have elastic cartilage. But with degenerative joint disease, we're referring to the hyaline cartilage that makes up the covering over the articular surfaces of adjacent bones that form the articulation. Well, a lifetime of chemical and physical forces starts to slowly create an alteration in the function of the chondrocytes, the cells that are responsible for producing cartilage. Let's just talk about cartilage for a minute here. If you remember back to histology, you remember that cartilage is one of the connective tissues. And there's about 7 or 8 different tissues that are collectively known as the connective tissues. And these 7 or 8 different types of connective tissues all have in common that they derive from the same embryonic mesoderm. They derive from the embryonic mesoderm. And interesting, all of the connective tissues share in common 3 basic principles. And that is that all of the connective tissues have cells associated with them. The cells all produce some sort of fibers, and the cells also produce some sort of extracellular matrix that surrounds the cells. So, for example, one of the connective tissues is blood. Believe it or not, blood is considered one of the connective tissues. Not because blood connects all the parts of the body, but because blood is derived from the embryonic mesenchyme, much as all the other connective tissues derive from the embryonic mesenchyme. So blood has cells associated with it. What kind of cells does it have? Well, it has red blood cells and white blood cells. Blood has associated fibers that are secreted by the cells. What are the fibers that are found in blood? Well, these are known as the clotting factors. These are fibers that are dissolved in solution, and upon a clotting event, they come out of solution as fibrinogen, and they become solidified into fibers. So we have cells, we have fibers. What is the extracellular matrix involved with blood? Well, we call that the plasma. So we have cells, we have fibers, we have extracellular matrix. Well, with cartilage, cartilage has cells. They're known as chondrocytes. The chondrocytes secrete fibers. They're typically collagen fibers, but also in the case of elastic cartilage, the chondrocytes secrete elastin fibers. And then the chondrocytes also secrete an extracellular matrix, which in the case of cartilage we refer to as ground substance. Ground substance. Now, the ground substance is composed of several different chemicals of which you're familiar. It's composed of hyaluronic acid. It's composed of chondroitin sulfate. And you've heard of patients who take the chondroitin and glucosamine sulfate in an attempt or in the hopes that taking these raw materials will enhance the ground substance and will enhance the integrity of the cartilage. Well, that is beyond the scope of this discussion, but suffice to say for our purposes that when we see altered chondrocyte function, the chondrocytes start to slow down their production of extracellular fibers and also extracellular matrix, which we refer to here as the ground substance. And you're all familiar with cartilage, and you've probably bitten into pieces of cartilage when you've eaten chicken. And the next time you have some chicken, whether it be a drumstick or what have you, I want you to pull those articulations apart and simply look at the articular cartilage that covers the ends of the long bones of the chicken. And if you take your fingernail and dig your fingernail into that substance, you'll see that it's durable and yet flexible substance. This is the articular cartilage. Well, over time, as the ground substance starts to thin and become aged, is probably the best word for it, the ground substance starts to develop cracks and fissures and fibrillations, and it flakes off and it becomes revascularized and hypervascularized, and the integrity and the properties of the articular cartilage begin to deteriorate and begin to soften. It's at this point that we start to notice a loss of joint space on an X-ray. And loss of joint space is one of the hallmark features of degenerative joint disease. On X-ray, we also start to see subchondral sclerosis and subchondral cysts. These are degenerative changes beneath the articular cartilage. It's subchondral. It's beneath the articular cartilage. We see erosions and cysts develop in the subchondral bone. And as the degeneration progresses, we ultimately see deformity and subluxation of the involved articulation. If we're talking about the knees, this may manifest as a genuvarum or genuvalgum deformity. With the hands, we may see an ulnar deviation of the fingers. All of this is also accompanied by some things that are not so readily apparent on X-ray. However, one of the hallmark findings that we associate with degenerative joint disease is soft tissue thickening. Soft tissue thickening. And on dissection, this is manifest as synovial hypertrophy. Hypertrophy of the synovial lining of the joint. And we'll talk a little bit more about synovial joints in just a minute so that we're all on the same page with the anatomy of this. So let's review then. Here we have a diagram of the hip joint. This is the femur, this is the acetabulum. And you can see here some of the typical findings that we associate with osteoarthritis. We have a deterioration of the cartilaginous weight-bearing surfaces of the articular joints. We see sclerotic changes in the subchondral bone, and I think you can see some sclerotic changes here in the subchondral bone of the acetabulum. We see the proliferation of new bone, which manifests itself as spurs and osteophytes, and we see some osteophytic development here at the superior margin and the inferior margin here of the acetabulum. And this provides us with our typical hallmarks that we associate with degenerative joint disease, and that is joint space narrowing, subchondral sclerosis, and soft tissue thickening. Now, soft tissue thickening is difficult to see on X-ray, but I encourage you the next time you have a patient in who has DJD of the hands, osteoarthritis of the hands, if you just look at those knuckles and you notice the thickening around the knuckles, some of that thickening is due to thickening of the soft tissues around that articulation. In particular, it's thickening of the synovial membrane that lines the inside of the articular capsule. So let's talk a little bit about synovial joints so that we're on the same page regarding osteoarthritis. And then once we have the anatomy established, we'll go ahead and go on to specific exercise recommendations for those patients with osteoarthritis. So let's go all the way back to our coursework in osteology back in first year of chiropractic school. And let's take a look here at a typical representative synovial joint. This could be, for example, a finger joint. Looks a lot like a finger joint. They're relating it here to a shoulder joint, but this could be any synovial joint in the body. Okay, so let's talk about the general anatomy of a synovial joint. Well, all synovial joints in the body, regardless of where we're talking about, have the following 5 features in common. Number one is the synovial joints, the bones that make up the synovial joints are lined with articular cartilage. Now, this articular cartilage is represented here in this diagram by blue, by the color blue. And if you remember from osteology, all of these bones, at least in the appendicular skeleton, form through the process of endochondral ossification. Endochondral ossification. So here is what's left of the epiphysis here. And so this was the last remaining vestige of the growth plate all of this was cartilaginous, and this was responsible for the elongation of this long bone through the process of endochondral ossification. Well, the only thing that's left at the conclusion of complete ossification is the articular cartilage. So these bones start out as all cartilage, no bone, and end up as all bone with no cartilage, with the exception of the tiny remaining articular cartilage at the end of the long bones. So we have this articular hyaline cartilage here that lines the end of both bones, forming up the articulation. And remember that this is hyaline cartilage. Cartilage has cells, it has fibers, and it produces, these cells produce extracellular matrix that we refer to as the ground substance. Okay? So that's the articular cartilage. Well, all synovial joints also have a synovial joint cavity. And it's the synovial joint cavity that separates the inside of the joint from the outside of the joint. And this cavity is formed by the articular capsule. And it's the capsule, as indicated here by this purple structure, fibrous capsule, that creates the dividing line between the inside of the joint and the outside of the joint here. The articular capsule is largely fibrous connective tissue, and like cartilage, the articular capsule is one of the connective tissues. It's formed from fibrous connective tissue, generally fibrous, dense, irregular, fibrous connective tissue. Now, because it's one of the connective tissues, it follows a similar pattern as does the cartilaginous tissue, meaning that there are cells associated with the fibrous connective tissue. Those cells are known as fibroblasts. Fibroblasts secrete extracellular fibers. Those include collagen fibers, those include elastin fibers. And then the fibroblasts secrete also an extracellular matrix. Now, in the case of dense, irregular fibrous connective tissue, the extracellular matrix is scant, is minimal, is not much, because most of this connective tissue is characterized by tightly packed collagen fibers, but there is scant extracellular matrix, certainly not to the quantity and as differentiated as is the extracellular matrix associated with a hyaline cartilage. However, there still is some degree of extracellular matrix. Okay, and then all synovial joints are characterized by synovial fluid, which is secreted into the interior of the synovial joint cavity. And then all synovial joints are characterized by the presence of reinforcing ligaments. And in this diagram here, we demonstrate or diagram a ligament here in purple. Now, a couple comments about the synovial fluid and also about the reinforcing ligaments. The synovial fluid is secreted into the synovial cavity here, and it's secreted by cells that line the interior of the synovial membrane. Synovial membrane is a sheet of secretory cells that lines the interior of this joint cavity. Now, the synovial membrane is generally a two-sided membrane. The interior side is secretory, and those cells secrete a substance that we refer to as synovial fluid. The exterior surface of the synovial membrane is continuous and contiguous with the articular capsule, and this exterior surface is composed of fibrous connective tissue. So the synovial membrane is a two-sided membrane, the interior of which is secretory, the exterior of which is connective tissue. Now, one of the things that we find as the degenerative process continues is that we see sometimes alterations in the quantity and the content of the synovial fluid. With synovial hypertrophy, we see increased production of synovial fluid. That's responsible for swelling that we associate with painful and degenerative joints. And then in late stages, we see that the content, the viscosity of the synovial fluid diminishes and reduces the weight-bearing content and the weight-bearing capacity of the synovial fluid. And so that allows greater destruction of the ends of the long bones. With regards to reinforcing ligaments, in this diagram here, we're showing ligaments that are extracapsular, meaning that they're located outside of the joint capsule. And this, for example, could be representative of the medial collateral ligament in the knee, for example. On the other hand, some ligaments are intracapsular, and they penetrate the capsule and pass through the articular cavity, the joint cavity itself. And an example of an intracapsular ligament would include, for example, the anterior and posterior cruciate ligaments. Okay, so this is our basic structure of a synovial joint. We have articular cartilage, we have a joint cavity, we have the articular capsule, the interior of which is secretory and produces the synovial fluid, and then we have different types and classifications of ligaments that provide stability to the joint. Those ligaments can be either intracapsular or extracapsular. Now, in addition to those structures in and around synovial joints are also associated with other structures. And let's talk about some of these, because these are going to become important when we talk about rehabilitation recommendations for the shoulder joints and the knee joints. So some of the friction-reducing structures that we become involved with include the bursae. Bursae is plural for bursa. Now, what bursae are flattened fibrous sacs lined with synovial membranes and containing synovial fluid. So if you think about a bursae or a bursa is really the same thing as a synovial membrane that we saw in and around your standard synovial joint. At the standard synovial joint, we had a synovial membrane with an inner secretory layer and an outer fibrous layer. Well, bursae are exactly the same, except the bursae are flattened sacs, the interior of which is lined with synovial fluid, the exterior of which is fibrous connective tissue. And the purpose of bursae is to create friction-reducing surfaces for areas where there are repetitive motions of tissues. So we find bursae commonly where ligaments, muscle, skin, tendons, or bones either rub together or rub across each other. And we're going to see that the shoulder and the knee are replete with bursa sacs. Also, friction-reducing structures that become involved and become pathologic in degenerative joint disease and with injury conditions include tendon sheaths. Now, think of a tendon sheath as simply a bursa sac surrounding tendons. These are common in the shoulder, these are common in the hands. And what these flattened fibrous sacs do is they reduce friction in areas where tendons undergo repetitive motions, such as in the hands, such as in the feet, and such as in the shoulder. So here's a diagram that illustrates both of those structures. Here is our synovial joint, the glenohumeral joint. Now the synovial joint of the glenohumeral joint has all of those features that we associate with an articular synovial joint. It has articular cartilage. The articular cartilage is indicated here in blue. This is hyaline cartilage that covers the surface of the humerus bone. The glenohumeral joint also has a joint or synovial cavity. That synovial cavity is illustrated by this space right here. The synovial cavity is separated and surrounded by the articular capsule. The articular capsule is indicated here. Here is the fibrous portion of the capsule. Here is the upper fibrous portion of the capsule. And then the inner portion of the capsule is the secretory layer, indicated here and described as the synovial membrane. Finally, reinforcing ligaments are indicated and suggested here. Here's the coracoacromial ligament, and there's many other ligaments that are not depicted here, both intracapsular and extracapsular. So in the case of the shoulder, we see here is the synovial cavity. And the synovial cavity simply projects an extension of itself and folds upon itself to create a tendon sheath. And in the case of the shoulder, we have a tendon sheath that surrounds the tendon of the long head of the biceps muscle. The tendon of the long head of the biceps muscle is an intracapsular tendon. It penetrates the joint capsule to attach on the glenoid labrum at the superior aspect of the glenoid cavity. So this is an intracapsular tendon, and it has this tendon sheath wrapped around it, the purpose of which is to protect it. It's protected by this fibrous connective tissue layer here indicated in green, and it also lubricates and reduces friction for repetitive motions of the bicep tendon as the shoulder goes through repetitive motions. So there's a tendon sheath, and then here we have a subacromial bursa indicated here. This is the acromion process of the scapula. Here is a flattened fibrous sac with an inner synovial secretory layer indicated here. It says cavity containing synovial fluid. And the purpose of that, again, is to reduce friction for repetitive motions at the shoulder. So this is important to know the structure of these anatomic. It's important to know the anatomy of these structures because these structures frequently become pathologic and involved in our rehabilitation process. Now, let's talk about synovial joints and the stability of synovial joints. Now, I want you to think about some of the different synovial joints in the body, such as the knee joint, such as the hip joint, such as the shoulder joint, and you'll agree that those joints each have their own individual levels of stability, and the stability of those joints differ greatly. In other words, the shoulder joint, while it's a much more mobile joint than the hip joint, is a much less stable joint than the hip joint. So let's talk about some of the factors that contribute to the stability of joints. And this is going to be important to understand because our rehabilitation protocols have to address joint stability and the maintenance of joint stability and the maintenance of the neuromuscular control of joint stability. And we'll get into this in great detail, specifically when we talk about rehabilitation recommendations for shoulder instability. Okay, so the first thing that contributes to the stability of synovial joints is the shape of the articular surfaces. And it's the shape that determines what movements are possible. So if you think of the shape of the articular surfaces of the glenohumeral joint, you know that we have a ball at the head of the humerus and a very small, shallow socket, not even a socket at all, more like a plate of the glenoid fossa. So because this is a very shallow surface, this permits a wide range of motion, however, is a very unstable arrangement. Now conversely, the femoroacetabular joint of the hip has a much deeper articular surface of the acetabulum than is the surface of the glenoid fossa. And so this creates a much more stable joint for weight-bearing purposes. But what we gain in stability, we sacrifice at the expense of stability. And that stability is largely governed by the shape of the articular surfaces. Now, number two factor that contributes to joint stability are the ligaments that span the joint. And as we said, we have both intracapsular ligaments and extracapsular ligaments. And the purpose of ligaments is to unite bones and prevent excessive or undesirable motion. And ligaments can be injured, and ligaments can be involved in our rehabilitation prescription. Remember that ligaments are also one of the connective tissues. They're formed primarily from fibroblasts, which are secretory cells. They secrete strong collagen fibers, generally arranged in a parallel organized fashion that is strong and resistant to tensile or pulling apart forces. So you might think of the medial collateral ligament or the anterior cruciate ligament. Those are composed of dense, regular, fibrous connective tissue that prevent excessive or undesirable motion and thereby stabilize the joint. Now, with injury and injury to ligaments, we find structural instability of joints, and structural instability of joints is undesirable because that leads to premature degenerative change of the joints, and this is going to be one of our targets in our rehabilitation. Finally, and importantly, muscle tone contributes also to the stability of synovial joints. And all muscles in the body have a resting tonic discharge. We call that the muscle tone. And it's the tendons that cross the joints that provide the stability. And it's the muscle tone that provides the resting tension of the tendons across the joints. Now, tendons are kept tight at all times by muscle tone, and this is especially important in the shoulder, in the knee, and in the lumbar spine, as we will discuss. And this is important for our rehabilitation protocols because many of the injuries that we see in the chiropractic office involve simple muscle strain injuries. Well, one of the complications of muscle strain injuries is that we lose the functional stability due to altered muscle tone. And as the muscle tone becomes altered, the tension on those tendons that crosses the ligaments become pathologic, and the joint becomes structurally and functionally unstable. You may have experienced this yourself if you've ever had a shoulder injury. Perhaps you had a strain of your rotator cuff, and you notice now that when you move your arm in certain directions, there's a click or a clunk or a shifting feeling or a sort of gristle sound that comes from the joint. And this is excessive motion in the joint as a result of alterations in the balance of the muscle tone of the tendons that cross the joint. It's particularly common to see these aberrations in the shoulder, because the shoulder is largely, and to a much greater extent than some of the other joints, is largely stabilized by muscle tone across the joint. So this also is going to be one of the targets of our rehabilitation efforts, is to reestablish functional and structural stability of. Okay, so before we get into exercise procedures for osteoarthritis, let's just review some of what we've talked about here. Here we have a large weight-bearing joint. This is the femoroacetabular articulation. And you see that the end of the femur bone is covered in articular hyaline cartilage. Articular hyaline cartilage. The epiphysis of this head of the femur would probably be right about here, right about through here. This is obviously now an adult bone, and the epiphysis has long closed. And what was the remainder of the cartilage? It remained as the articular hyaline cartilage. Well, over years and years of physical and chemical forces, the articular cartilage has begun to erode and develop fissures and fasciculations and fibrillations and altered metabolism. And basically, we say that the cartilage has thinned, and the joint space, as a result, starts to narrow. Well, as the joint space starts to narrow, we start to see changes in the adjacent bones themselves. Now, we can't see on this particular diagram because this is not an X-ray, but we would typically see on X-ray changes in the subchondral bone up here in the surface of the acetabulum, and changes in the subchondral bone here below the articular cartilage of the femur. We refer to those as subchondral cysts, subchondral erosion, sometimes referred to as subchondral geodes. Also, we see here the formation of osteophytes and bone spurs, and here it's shown on the superior aspect of the acetabulum, but you can expect osteophytes and bone spurs to form generally circumferentially around the margins of the articular surfaces. Now, because of these changes of the joint, this is typically going to be a joint that's going to be associated with some level of pain. And it's generally the pain that brings the patient to our clinic for treatment and for rehabilitation recommendations. So consistent with the principles that we described earlier, how can we approach the rehabilitation of this joint? Well, consistent with the principles that we described earlier, this is something that we're going to want to protect, and we're going to want to prevent further injury and further damage and further degeneration of this joint. However, we need to maintain as much as possible the general health of this patient, both locally in and around this joint, and then also systemically throughout their whole body. So what can we do? What are some general ideas? What are some general guidelines? And what are some general rehabilitation principles for degenerative joint disease? Well, we want to protect this joint and prevent further damage to the joint. So therefore, high impact activities and high loading activities are going to be contraindicated. For example, some high impact activities, if we're considering the knee joint or the hip joint, would involve running, would involve jogging, would involve snow skiing, would involve anything involving jumping, landing activities. Anything that's going to cause repetitive and high impact is not going to be good for the joint, and it's going to contribute to further damage to the articular cartilage and to the bone itself. Again, high resistance or high loading activities such as squats and lunges if we're talking about degenerative changes of the spine or of the hips or of the knees. Those won't be good. If we're talking about the upper extremities, such as the shoulder, push-ups and full range of motion bench presses that are heavily loaded are not going to work very well and are going to exacerbate the patient's condition. It's going to exacerbate their pain, and it's going to accelerate the degenerative change. For that reason, and in general, unless the patient can tolerate it, we begin by eliminating the closed kinetic chain activities, opting instead for what we refer to as the open chain kinetic activity. Now, we're going to be referring to open and closed kinetic chain exercises throughout this program, so let's just clarify what we mean by open and closed kinetic chain exercises. This is a concept that comes out of exercise physiology. And as a chiropractor, you will understand and agree that the joints and articulations of the body form a series of interrelated linkages that can be referred to as a kinetic chain. Well, the kinetic chain describes the collective effort or the collective involvement of two or more sequential joints to create movement. So, for example, when we walk, the articulations of our lower extremity from the toes into the forefoot, into the midfoot, into the rear foot, into the tibia and fibula, up into the knee and up into the hip form a series of linkages that all work together in what we refer to as a kinetic chain. And any alteration of any one of those articulations disrupts the function of the kinetic chain and creates more stress on one or more sequential joints in the chain. Well, when we refer to a closed kinetic chain, we mean that the terminal joint is stationary, or that the terminal joint is where the majority of the resistance or the restriction to motion occurs. Typically, we think of closed kinetic chain activities as those activities wherein the distal joint is stationary. So, for example, an example of a closed kinetic chain activity would be, for example, squatting down to pick up something off the ground. In this case, the lower extremity joints act sequentially to create movement, but the distal joint, meaning the foot, the distal joint, is stationary. And it's the knees and the hips which are mobile. Now, in contrast to a closed kinetic chain movement, an open kinetic chain movement involves a movement in which the terminal joint now is free to move versus stationary as in the closed kinetic chain. So the open kinetic chain allows for great concentration on an isolated joint or on an isolated muscle, whereas closed kinetic chain activities generally involve multiple joints and multiple muscles. So with our patients that have degenerative joint disease and loss of joint space and all the changes associated with joint degeneration, we begin their exercise rehabilitation with open kinetic chain activities that allow us to concentrate our focus and concentrate our effort on isolated nearby joints and allow us to eliminate or minimize motion and loading on the involved joints. So we begin with open kinetic chain activity. So here's a diagram that shows both some upper body and lower body exercises. The upper diagram shows the athlete, in this case, performing squat maneuvers. And you'll notice that when the examinee or the patient does squat maneuvers, the feet remain in contact with the ground. The feet are the distal joints involved in the kinetic chain of the lower extremity. Here's the lower extremity involving the hip, the knee, the ankle, and the foot remains stationary as the athlete squats down and rises with the bar. This is an example of a closed kinetic chain. Now, with regards to upper body exercises, here we see this athlete performing push-ups. Now, note that the distal extremity, the distal joint in the kinetic chain of the upper extremity, the distal joint remains fixed, and the body moves around the fixed distal extremity. Now, closed kinetic chain activities involve multiple joints, multiple muscles, multiple articulations. They're referred to as compound movements, and this is very stressful and contraindicated in our patients with degenerative joint changes. Rather, we begin them with open kinetic chain activities, such as would be seen here with the leg extension exercise. Now notice with this exercise, the kinetic chain of the lower extremity, including the ankle, the knee, and the hip, here the distal extremity at the foot is mobile and the proximal joints are stationary. That was in contrast to the closed kinetic chain activity where the foot was stationary and the proximal joints were mobile. So we begin our osteoarthritis patients rehabilitation with open kinetic chain activities, progressing only to closed kinetic chain activities when the patients have successfully mastered the open chain kinetic activities and when closed kinetic chain activities and movements are completely pain-free and well tolerated. So what can we suggest for these types of patients? Well, how about aquatic exercise and other limited loading and limited weight bearing activities such as swimming, such as biking, such as elliptical trainer, and other supported types of exercise apparatus that reduce weight-bearing load on painful joints. Also recommended for osteoarthritis and joint degenerative changes patients are balance and proprioceptive training exercises. And the purpose of balance and proprioceptive training exercises is to help maintain the neuromuscular control of the involved extremity and of the involved articulation. And as we said at the beginning of this program, pain and inflammation are inhibitory to alpha motor neurons. So pain in and around a degenerative joint, say for example pain in and around the knee, is going to be inhibitory to muscles that act at the knee. So what muscles act at the knee? Well, the quadriceps act at the knee, the hamstrings act at the knee, the gastrocnemius acts at the knee, and all of these muscles are going to be subject to various levels of inhibition. Well, with inhibition comes loss of joint stability, as we talked about with relation to muscle tone and the tendons that cross joints, and altered neuromuscular control of that articulation. And this is where balance and proprioceptive training serves as one method to restore and reestablish neuromuscular control of that painful joint. So here's a couple examples, show some people doing water activities. The good thing about water activities is they give a tremendous workout to the muscles while relieving the weight-bearing stress from the joints. And if you've not done a water aerobics class, I challenge you to do it because it's a lot more vigorous and it's a lot more of an exercise effect than you might imagine if you've never done it. Here is an athlete working on the elliptical trainer. And I love the elliptical trainer for many reasons. For our joint degenerative change patients who need rehabilitation, I love the elliptical trainer because it's very smooth and it alleviates weight-bearing stress and impact from the knee joint, from the hip joint, and from the spine joints. Gives a great cardiovascular workout. And also because it can be used in a variety of ways to restore neuromuscular control of the lower extremity kinetic chain joints. So let me give you some ideas as to how you can recommend the elliptical trainer to your patient. Now, for the establishment of neuromuscular control, I want to give you some ideas on some protocols and progressions. And I encourage you to try these yourself. You're going to find a fascinating phenomenon when you try these exercises yourself. And I submit to you that if you can progress through these protocols and master each of these protocols, it will give you tremendous benefit in terms of your joint stability, in terms of your balance, in terms of your coordination and the timing and the sequence of your movements. And I submit to you that will actually make you smarter, and it will strengthen the function of your nervous system generally. So I challenge you to try these progressions. And some of these might not be appropriate for your patients, but I simply give them to you perhaps for yourself or perhaps for some of your exceptional patients. So imagine that you jump onto an elliptical trainer, and the elliptical trainer has movement taking place at the hands and also at the legs. Well, entry-level use of the elliptical trainer involves holding on to the handles and keeping the handles and the legs moving simultaneously with your eyes open while you concentrate on every step and every component of the cadence, and you're conscious about every movement. Well, as you get a little bit more accustomed to using the elliptical trainer and you get the motor pattern of it established, you might find that if you close your eyes, you get a different training effect. So I challenge you to try this. Leave your hands on the handles, continue with your cadence, but close your eyes and feel your feet and feel the sequence of the motions through the ankles, through the knees, through the hips, and become accustomed to the feeling of these motions, the neuromuscular sensation of these motions with your eyes closed. Closing your eyes reduces all manner of visual input and gives you no frame of external reference upon which to focus, thereby causing your focus to turn internally to the articulations of your lower kinetic chain. Now, once you get this motor pattern established and you establish good control, you can then proceed on to the next progression, which is to take your hands off the handles but keep your eyes open. This requires quite a bit more balance to let go with your hands, but to maintain your balance without falling off the elliptical trainer and still maintain the cadence provided by the trainer. Once you get this mastered, you might try that same progression now with your eyes closed. So we're doing no hands, no eyes. This requires tremendous neuromuscular control of the lower extremity, without which you will fall flat on your face and suffer great injury. So progress through this cautiously and keep your hands close to those handles should your balance falter. Next progression would be to do the elliptical trainer no hands, no eyes, and now introduce some perturbation challenges. Perturbation challenges could involve some motions of the arms, for example. Motions of the arms that throw the center of mass of your body away from the center of rotation of the elliptical trainer. Other perturbation challenges could include, for example, cervical spine lateral flexion to the right, and then cervical spine lateral flexion to the left. This introduces the added complexity of altered mechanoreceptive input through cervical spine joint mechanoreceptors. And so it's your lower extremity neuromuscular control that has to compensate and correct for this afferent barrage coming up into your brain, telling you about the position of your head with respect to your body. Next progression might involve the same perturbation challenges, now with integrating some sort of cognitive challenges, such as saying the alphabet backwards, such as doing subtraction from 100 backwards, such as naming all the words you can think of that begin with the letter C-A-T, and all kinds of cognitive challenges while still maintaining your cadence on the elliptical trainer, no hands, no eyes. Another example that you can use is you can introduce some cranial nerve exercises to exercise the brainstem and the cranial nerves. So you can do the elliptical trainer, no hand, no eyes, and go through some exercises for cranial nerve number 1, such as inhaling and sniffing to stimulate the olfactory nerve, such as reading a magazine to stimulate the optic nerve, such as doing cardinal planes of gaze exercises to stimulate cranial nerve 3 and cranial nerve 4 and cranial nerve number 6, and doing muscles of mastication exercises and running through all of the cranial nerves, including the tongue exercises and exercises for the trapezius and the sternocleidomastoid for cranial nerve number 11, and tongue wagging exercises and tongue protrusion exercises for cranial nerve 12. And really, the different types of balance and proprioceptive exercises that you can prescribe for your patients on the elliptical trainer are really basically unlimited, really limited only by our imagination. And let me tell you, if your patient is able to go through these progressions, it will do wonders for the neuromuscular control of their lower extremity and will help preserve the useful function of the degenerative joint in question. Other options for balance and proprioceptive exercises include Bursae ball or unstable type of work. Here shows a patient on various progressions of unstable surfaces. Here he's doing a single leg stance, which is an proprioceptive exercise for the entirety of the right lower extremity here. Next progression would be to do this with the eyes closed, for example. Here shows the examinee on an unstable surface with both feet. Next progression would be perhaps both feet but closed eyes, or 1 foot open eyes, or 1 foot closed eyes. Here he is 1 foot on an unstable surface but with eyes open, and the progressions on this are endless. Here shows a patient using a Bursae ball. This is an unstable surface that, if you've ever tried a Bursae ball, the amount of activity that takes place in the ankles and knees is tremendous. And this is a brilliant device for rehabilitating lower extremity articulations. And here she goes through various motions, all the while maintaining her balance without falling off of the Bursae ball. So tremendous amount of options, and the possibilities are really. Finally, here's some examples of open kinetic chain activities that relieve weight bearing from painful and degenerative joints. This is an open kinetic chain activity, different from the push-up, because here the distal extremity is free and is the mobile portion of the kinetic chain. This athlete has added the additional difficulty of having an unstable surface here. And so this unstable surface creates additional stabilization required through this upper kinetic chain. And this creates a therapeutic and submaximal isometric contraction of joint stabilizers in and around the shoulder joint. This patient on this side, again, is on an unstable surface. The distal extremity joints here of the torso are free to move in an open kinetic chain, and she has the added complexity here of an unstable surface, which requires joint stabilization through the lower extremity and through the lumbar spine. So these are just some examples of rehabilitation protocols that you can apply to your osteoarthritis or degenerative joint disease patients. Again, the general principles are to alleviate impact, to alleviate load bearing, to minimize the use of closed kinetic chain activities in favor of open kinetic chain activities, and then finally to integrate a large proprioceptive and balance demand to maintain, retain, and to train the neuromuscular control of the degenerative joint. Okay, so I hope that helps you. That's going to apply to many of your patients as more and more patients present with clinical and exam findings associated with joint degenerative changes. Let's now move on and talk about exercise rehabilitation protocols and procedures for various lumbar spine conditions.